Hi, everybody. Thank you very much for joining me for a short session about amyloidosis, predominantly cardiac amyloidosis. I'm Dr. Savir Baruch. I'm a member of the Society of Nuclear Medicine and Molecular Imaging, also boarded nuclear medicine physician and boarded in nuclear cardiology. So what is amyloidosis? Amyloidosis got its name because of the shape of the amyloid plaques that are accumulating in different organs. At some point in the production of the protein, this protein underwent misfolding, and as a consequence, the body at this point cannot break it down and wash it out, and this is why it starts to accumulate in different organs, creating different diseases. Now, depends on the organ it accumulates, the clinical scenarios may be different from each other, but if it does accumulate within the cardiac muscles, this is where we have what it calls cardiac amyloidosis. Cardiac amyloidosis can happen due to genetic mutations, and it also can happen due to older age. Now, when the clinical suspicious of cardiac amyloidosis already happen, and it usually happens in the cardiology clinic, this is where chain of exams is going to start. And why is that? We have two types of cardiac amyloidosis, and we would like to differentiate the two subtypes because each one of them going to have a different clinical presentation, different management, different outcome even. So the first type that we want to exclude calls AL amyloidosis, and the longer version of it calls immunoglobulin light chain amyloidosis. This is the first time we would like to exclude, and we do it by simple blood tests and urine tests, and we're looking for light chain fragments within the body. And if we detect that there is light chains within the urine or the blood, also known as monoclonal protein detection test, the next step is to confirm it by biopsy. So when we actually do biopsy, we can do it from the abdominal fat, and if we need, we can also do it directly from the heart. If those tests are positive, now the diagnosis of AL amyloidosis is done and the patient can start having management. Now, if those tests are negative, if the urine and blood tests are negative, we don't even need to do biopsy. Now, the next step is to start excluding or diagnosing what it calls ATTR cardiac amyloidosis, also known as transthyretin cardiac amyloidosis. So ATTR amyloidosis can be diagnosed in the nuclear medicine division. And why? It's because we have what it calls a PYP nuclear medicine bone scan. The PYP actually is a calcium-seeking agent. So when we inject the tracer to the patient and the patient has ATTR amyloidosis, it will create accumulation of calcium, which will attract the PYP into the cardiac muscles. So now you know the connection between a bone scan to cardiac amyloidosis. Why are we using nuclear medicine PYP bone scan exam to diagnose cardiac amyloidosis, ATTR amyloidosis? So when the PYP starts to accumulate within the heart, studies actually shown that if the uptake is equal or above that of the ribs, meaning grade 2 or grade 3 uptake, now we know that the sensitivity and the specificity of ATTR cardiac amyloidosis is above 90%. Let me take it even further. If we do quantitation and we do region of interest and we put it above the heart, and then we take the same region of interest and we put it around the contralateral chest, the other side, and we calculate the counts within the heart and we calculate the counts within the contralateral chest, also known as cardiac to contralateral chest ratio. If the ratio in uptake is 1.5 and above, now the sensitivity for the diagnosis of ATTR amyloidosis is 97%. The specificity is 100%. So what is the meaning of it? If I have someone that comes to my clinic and they have a negative urine and blood test for AL amyloidosis and their bone scan, PYP bone scan is positive, Now we can make the diagnosis of ATTR amyloidosis. And if the bone scan is negative, now we know that the likelihood of ATTR amyloidosis is very low, and the patient should go back to the cardiologist to look for other etiologies for their cardiovascular symptoms. In other words, we don't need to have biopsy. Thank you very much. I was Dr. Savir Baruch, and a member of the Society of Nuclear Medicine and Molecular Imaging, and thank you for joining me for this short session.